And Grace, you see my screen, right?
Yes, I can see your screen. Thank you.
Okay, perfect. So today we'll see how we can recognize the Auto-PEEP or the dynamic hyperinflation syndrome. We can talk about how we can solve the problem, and then if we have time, we can talk about some advanced concepts related to dynamic hyperinflation. Like usual, I need a volunteer to participate and see how we can detect what's going on the ventilator here. This is a patient who was admitted with asthmatic attack or crisis, was intubated, placed on mechanical ventilation. Saturation is 97%, and the patient is sedated. He's not breathing, as you can see. So who do you want? Anybody wants to see what can we detect on this graphics on the ventilator? Any volunteer? So we have anyone? So waiting for people to start interacting with us. So let's just see what we see here on the ventilator. Of course, this is mandatory mode of ventilation, even though it says here SIMV, but the patient is not breathing at all. This is mandatory mode of ventilation, and each breath is started by the time trigger that triggers the ventilator. And we have volume control here. The control is 520 ml, and the rate is set at 18. So what you notice here that first we have that increased airway pressure. You can see the rise in the airway pressure from the PEEP level here to the initial point in the pressure over time curve here. And then we have steady increase in the pressure to get to the peak inspiratory pressure. And you can see the peak inspiratory pressure is probably at 42, 43. And then we have a plateau. So the inspiratory time is not finished. However, the tidal volume is delivered to the patient. And then we still have time in inspiration. That is why the pressure went down to plateau level. This pressure is needed to keep the air in and overcome the lung and chest wall compliance. You can see the flow here is at 0, meaning that there is no air going through the airways. And that's why we don't need the pressure to overcome the airway resistance. And that's why the peak inspiratory pressure went down to the plateau level. So you can detect that there is a high airway pressure here from the initial rise here, and a difference between the peak and plateau is also high. However, notice that the difference between the peak and the plateau is not as high as the increase in the initial airway pressure. You can see how high the pressure goes first compared to the difference between the peak inspiratory pressure and the plateau pressure. So this is the first abnormality that you detect. This pressure is the airway pressure because of the airways. This pressure is the pressure required to overcome the Auto-PEEP and the airway resistance. Now you go to expiration, and you will see that expiration starts here, and the flow goes to negative expiratory flow. That's a peak expiratory flow here. And then what you notice is it goes up gradually. The slope is actually much less steeper compared to a normal case. You can see that there is a limitation to the expiratory flow in all the points here. And when the next breath comes, the lung is not completely emptied yet. You you can see that there's persistent flow at end of expiration. And if we did not have the next breath, this patient would continue to exhale all the way here, and he would need longer expiratory time for complete exhalation. And if you take a look on the area under the curve, what you see here, and if you can actually calculate this, the area under the curve here in inspiration, this is higher than the area under the curve in expiration. Of course, this is just visually, you can estimate it. If you continue, if you prolong the expiration, you would see that you would add area under the curve, and then both would be equal. The area under the curve on the flow over time curve would represent the volume. So we know that the volume that is inspired is not is not the same as the volume that is expired. There's a trapped volume inside the lungs that is not exhaled. So the characteristics of dynamic hyperinflation: number one, the airway pressure is higher than the initial airway pressure is high. Number two is limited expiratory flow. Number three, there's air trapped, represented by persistent flow at end of expiration, and difference in the volume between inspiration and expiration, which is the air trap. So this way you can make a diagnosis that we're dealing with an auto-PEEP. If you hold expiration, you would be able to measure the auto-PEEP for the patient, and you can have an estimate of what is the pressure in the alveoli. Now, is there any question before I move to the next step? Okay, so I just wanted you to know the difference between dynamic hyperinflation and increased airway pressure. Now, dynamic hyperinflation does not have to be secondary to asthma. Okay, so you may have a patient who's put on the ventilator, and if you set the rate at higher rate where you don't have enough expiratory time, at that time you build up auto-PEEP for the patient. The air that is inhaled is not completely exhaled, and gradually that residual volume will increase, and of course any volume will be associated with pressure, and that's why we say the pressure is increased, which is the auto-PEEP. So what's the difference between the auto-PEEP that is resulted from dynamic hyperinflation and the increased airway resistance? It's actually all related to that initial rise in the pressure and the difference between the peak inspiratory pressure and the plateau pressure. So you can see in increased airway resistance, this pressure represents the airway resistance and is exactly similar to the pressure that is to the difference between the peak inspiratory pressure and the plateau pressure. And everything actually representing the increased airway resistance, that pressure is required throughout the inspiration to overcome throughout the inspiratory flow time to overcome the airway resistance. Of course, once we hold the breath in the plateau phase of it, at that time, we don't need the inspiratory pressure anymore, and the plateau pressure is all what's required to overcome the chest and lung elastance. Now, compared to dynamic hyperinflation, okay, so we don't have increased resistance. However, we have auto-PEEP. So the pressure inside the alveoli is higher, and that is represented here. So when the inspiration starts, we need to overcome that pressure first, and you can see the rise in the airway pressure to this point here. And then the pressure goes up to overcome the airway resistance of course, it's the other way around. First, you overcome the airway resistance, and then you overcome the the pressure that is actually in the alveoli. But the sum of it would be the Auto-PEEP plus the airway pressure that is required to overcome the resistance. Now, you can see how the airway pressure is constant, but it is much lower than the increased airway resistance. This is a patient who doesn't have increased resistance in the airway, but there's dynamic hyperinflation because you probably set the rate too high for the patient, and then he doesn't have time to exhale all the way. And you can see the difference between the peak inspiratory pressure and the plateau pressure. The difference is similar to part of the initial rise in the airway pressure. So this is the airway pressure related to the airway resistance, which is the same as the difference between the peak inspiratory pressure and the plateau pressure. But the remaining rise in the airway pressure is what's represented, what's needed for the to overcome the Auto-PEEP. Now the other thing is, so you can see here that this is a patient with persistent flow at the end of inspiration that is actually happened after a normal breath here. So if you set the frequency at higher frequency, or if the patient sometimes breathe at higher frequency, you may not have enough time to exhale all the way. Now on the volume, you will be able to see that this is the inspired volume. However, since we're not exhaling everything, you will see that the volume goes down, but doesn't reach zero. Why? Because we have trapped volume, and this is what represents the trapped volume. Okay. Now, if you take a look on the area under the curve here in inspiration, you will see that the area under the curve here is higher than the area under the curve in expiration. The difference would represent the air trapped, or the trapped volume, which is on the flow over time curve, is represented by this wedge here. So if you have a loop and you have flow volume loop, what you will see, I think I have a better one for this. I think this is, yeah. Okay, so this is the volume and this is the flow. Inspiration flow goes up and then stays at the same level. It's square wave flow waveform, and then it goes down to zero. If you have a plateau, it will hold here for the plateau time before expiration starts. And then when it starts, the flow goes to the peak expiratory flow. You can see here there are some secretions in the airways. That's why it's actually vibrating a little bit. And then you would expect that the flow goes back to zero, which is this point. So it did not go back to zero. It stopped here. And you would expect that the volume would be completely out and would go back to zero here, and it did not. So the flow stops at this point where we have persistent flow and we have trapped air. So this is the persistent flow. The flow does not go back to zero, and we have trapped air into the lung. So this is the trapped volume. So this is what you see in dynamic hyperinflation on the flow volume loop. Any question here? So if not, I would like to call, I think Ala is here. Ala, if you can unmute yourself, please. And go back to to our patient here. Ala, are you with me?
Yes, with you.
Okay, so you joined a bit late, but this is a patient who has asthma and was placed on the ventilator. So, and we already detected that he has persistent flow at end of expiration, and limitation of the expiratory flow, indicating that this patient has auto-PEEP. How are you going to solve the problem of the patient? The patient's auto-saturation, by the way, was 97%, and if you do ABGs, his PCO2 was 44 millimeter mercury, and the pH is 7.36. So what's your approach to manage the ventilator for this patient and improve the dynamic hyperinflation syndrome?
Okay, to avoid hyperdynamic insulation, the first, I will decrease the rate from 18 to the 40.
Okay.
And I will, and regarding to the tidal volume, I will go to the 6 milli per kg according to the ideal body weight. And regarding to the time inspiration, I will prolong the expiration. I will go to the one inspiratory to up to 2. And because this is the volume control, I will go to the flow 60 or 80. And regarding to the PEEP, if the patient is sedated and plus muscle relaxant, I will give B0. And if the patient is not muscle spontaneous breathing, but in this wave there is no negative pressure, so I will put some B0.
Okay, so let's try to organize our thoughts. So remember, I gave you that the CO2 is 44 or 45, and the pH is 7.36. What does that mean? It means that, you know, this patient has a minute ventilation of 9 liters, right?
Yes.
We can see that. Okay, with this 9 liters, he's able to have adequate ventilation, and the pH is 7.36. So if you decrease the minute ventilation below 9 liters, because you first mentioned that you're going to decrease the rate. If I decrease the rate, you know, I can do that easily here and go down on the rate down to 12. Okay. And if I go down on the rate to 12, look at how much I lose out of the minute ventilation. So 9 liters is going down. Now we lost 500 multiplied by 6. That's 3 liters, going to go down to 7 liters. So what you expect, the pH is going to be more acidotic. Okay, yes, C improved the dynamic hyperinflation syndrome. But the patient is...
But I will accept permissive hypercapnia, so that's going to work.
Okay, so let's just go back and explain this better. Okay, so the first principle in dealing with dynamic hyperinflation syndrome is to maintain oxygenation and ventilation as much as possible. So I would accept permissive hypercapnia if I fail correcting the dynamic hyperinflation without affecting the minute ventilation. Okay, so decreasing the rate is not necessarily the first step that I would do. So I put it back to 18. And I'm putting the principle. So the principle is, number one, I want to improve things without affecting ventilation, if possible. PCO2 is 45. Any decrease in the minute ventilation is going to result into more acidosis. That's number one. Now, number two, what's my aim here? What do I need to do? I need to provide more time for expiration. So the reason why we have persistent flow is because we're cutting this early. And yes, by decreasing the rate, we can improve it. But it is not the first thing that we should do. What we should do is look at the inspiration here. And you will see that we have 1.5 seconds for inspiration. And in this 1.5 seconds, I'm able to deliver. I can actually go down to 500, make it easy so you can understand. We don't have to make difficult calculations. So the 500 at a flow of 30 liters per minute, I'm able to deliver that flow in 1 second. And then I'm holding for half second. I'm holding in inspiration for half a second. Why am I doing this? This patient is asthmatic and he doesn't have major problem with the oxygenation. He's in fact now is on 36%. We can make it 40% for you. So and the patient doesn't have major problem in oxygenation. So I don't need that long inspiratory time, and I don't need this patient to have a plateau at all. So the first thing you do is get rid of that inspiratory time here and give it to expiration. This way, you would prolong expiratory time without affecting the minute ventilation, right?
Yes.
Okay, so that's the first thing that we do. So I'm going to go down on inspiratory time where I would have no plateau at all. And look at what we did here. We improved the dynamic hyperinflation slightly, okay? Because now we added 0.5 second to the expiratory time, and you can see how we improved the dynamic hyperinflation, okay? Look at the minute ventilation, did not change. And then I don't have to do ABGs because I'm not changing the minute ventilation. I kept the same minute ventilation, so that means the patient is going to, probably the ventilation is going to improve because now I'm actually relieving the auto-PEEP for the patient. What's the next step that you can do? Ala. Anybody else, if you want to participate, please raise your hand and unmute yourself. Well, we can't hear you very well, Ala.
The tidal volume,
Okay.
6 milli-kg.
Okay. So the next thing you said that you're going to decrease the tidal volume. Is that correct?
Yes.
Okay. So if you decrease the tidal volume, what will happen to the minute ventilation?
Will be decreased, and I will expected CO2 necrosis also as
okay, so is that the most appropriate thing to do at this point, or you have different things that you can do on the ventilator first before you start decreasing the minute ventilation?
And increases the flow to the 60
Excellent.
or 80.
All right, perfect. So what we need to do is, well, now we have a flow set at 30 liters here. And for 30 liters per minute, and we need to deliver 500, that takes 1 second. So why don't we deliver this faster? If I go up on the flow, and this flow goes up, let's just double the flow to 60. Okay, so flow of 60 now, and let's see what happens. Look at this. So we're able to deliver the same tidal volume faster. Of course, that's going to be associated with an increase in the peak pressure because it's higher flow. Okay, but the plateau pressure is the same. It did not change. So all this is actually central to the airways. It's centered in the airways. It's not probably transmitted to the lungs much. All right, and now as a result of increased flow, you can see that we get again the plateau back. So when we increase the flow, we did not gain anything towards the expiratory time. And now we can decrease the inspiratory time down to minimum time that is required, which is now 0.5 seconds. So I'm able to deliver. Can you please mute yourself if you're not talking? So now we eliminated the plateau again. And you can see that we were able to almost eliminate the dynamic hyperinflation without changing the minute ventilation. You can see the minute ventilation still around 9 liters. However, the dynamic hyperinflation or the auto-PEEP almost resolved. So I was able to eliminate the auto-PEEP without touching the minute ventilation. Okay, so let's just say if the condition was even worse and the patient still having persistent flow at end of expiration, what's the next thing that I can do? So now I maximize the flow, minimize the inspiratory time, maximize the expiratory time. What else I can do on the ventilator to decrease? You can see now how we gained back some dynamic hyperinflation here. Okay.
Can I answer?
Yes, go ahead, Dr. Nawar. Okay.
Can I apply a careful application of extrinsic PEEP, 80% of intrinsic PEEP, and can I apply it as extrinsic PEEP?
Okay, so if you apply extrinsic PEEP, so this patient is not breathing. Okay, everything is given by the machine. And you can see you can add extrinsic PEEP. You can add PEEP of 10 to this patient. Okay, and you can see how the PEEP is increased here. Why would the auto-PEEP get eliminated? You can see here that you still have, see that? You still have persistent flow at the end of expiration, and it did not really help. So why is that? Patient is not breathing, and that the concept of adding PEEP to auto-PEEP patient is not for patients who are on mandatory support ventilation. This is if the patient started to breathe. In order for this patient to breathe, he needs to drop the airway pressure. He needs to drop the intrathoracic pressure to a level lower than the auto-PEEP. So he has to exert himself in order to create a gradient between the airways and the alveoli and get the inspired air. However, if the patient is not breathing, the machine is doing this. The machine, that's initial rise in the pressure. This is what the machine is doing to overcome the auto-PEEP. So adding PEEP to a patient who's not spontaneously breathing will not help you. However, your answer is correct if the patient is breathing on his own, but it will not affect the auto-PEEP. It will only decrease the work of breathing for the patient. So the patient doesn't have to inhale deeply to overcome that pressure. So let's go back. And this is one way, yes, if you cannot get rid of the auto-PEEP, and if you put the patient on pressure support ventilation, at that time, yes, you can add PEEP to the circuit to equalize the pressure in the airways with the pressure in the alveoli. Okay, so again, the auto-PEEP is a pressure built up in the alveoli. So the alveolar pressure is higher than the airway pressure. And then by adding external PEEP to the airway pressure, you equalize the pressure between the airways and the alveoli, so the patient does not have to exert so much efforts to take inhalation.
Okay, can I decrease the respiratory rate?
Excellent. So we have two steps in approaching auto-PEEP. The first one is I want to do the maneuvers that would decrease auto-PEEP without affecting the minute ventilation. Okay, and what we did is, number one, we decreased we eliminated the plateau, And number two, we deliver the volume faster. And by delivering the volume faster, we created more time for plateau, and then we eliminated that plateau time, and the auto-PEEP decreased but was not eliminated. Now the condition got worse, and the condition got worse, and you can see here that the volume got less, so the 500 is not delivered. That's why the minute ventilation is already low, 6 liters. We lost 3 liters. So this patient, you need to expect that this patient is already acidotic because we lost 3 liters. Now, if I go down on the rate, I can actually go down to 12 per minute, and it can eliminate the auto-PEEP. You can see here there's minimal persistent airflow at end of expiration. However, the minute ventilation is going to go much lower, and the pH is going to be very acidotic. So now you would ask yourself, should I accept the hypercapnia and the acidosis and accept what we call permissive hypercapnia? But that's after you maximize everything that you can do to deliver the tidal volume that is set on the machine. You cannot deliver the tidal volume. At that time, you have a rate that can be decreased, or the tidal volume itself that can be decreased. So again, the interventions that you do on the ventilator for dynamic hyperinflation would be, number one, eliminating any plateau time in inspiration. Number two, deliver the tidal volume faster to create more time towards expiration. This way you won't affect the minute ventilation. Now, if you maximize the inspiratory delivery of the air, if you deliver the air very fast and maximize that, and the dynamic hyperinflation is not resolved yet, then the next thing you can do is either decrease the tidal volume or decrease the rate. And you should know that by doing this, you're going to decrease the minute ventilation for the patient. And then the patient becomes hypercapnic and more acidotic with respiratory acidosis. You can accept a pH of 7.20 or above. And if it goes lower than this, you may start the patient on bicarbonate to counteract or to correct the severe respiratory acidosis for the patient. Any question?
Yes, what question is that? Regarding to the severe bronchial asthma, it's not like ARDS. Except that we have the patient, the pH decay is maybe 7.1. Okay, so my priority now is increase the RR, prevent auto-PEEP, because the 7.1 it will be a risk after get sodium bicarbonate. Is my opinion is correct or not?
I'm having difficulty. I think you're talking, either you're in the car or something. It was very difficult to understand what you mean by the question. Can you summarize the question? I heard that the patient is very acidotic and 7.10 pH. So what was the question?
Now the aim, the priority, it is elimination the hyperdynamic insulation or increase the RR to avoid the respiratory arrest after sodium bicarbonate.
So it's actually, you need to maintain adequate pH for the patient, because if the patient, for example, is hemodynamically unstable and requiring vasopressors, at that time, acidotic media is not good for the patient. And we don't really understand the consequences of putting patients on bicarbonate in terms of intracellular acidosis or intracellular acid-base balance. So we don't know whether this is good or bad. We try to avoid using bicarbonate infusion as much as possible, but I don't want the pH to go below 7.15. So in severe cases, I'm okay with pH 7.16, above 7.15, and below that, I may have to start bicarbonate. Now, in terms of do we tolerate dynamic hyperinflation or not? Well, sometimes you may have to tolerate it, and it is really complex to understand what happens next if you do not resolve completely. I'm trying to get the slides. I have some slides for that actually, which explains what happens next. Okay. So your question actually generates more ideas towards, and I think this will explain it. So if the patient is on volume control mode of ventilation, meaning that this is the volume that the patient is getting, fixed volume, okay? Everything below this is what we call the functional residual capacity. So this is the FRC, and the patient is breathing above that. Okay. And if the patient is developing dynamic hyperinflation, what happens is the pressure builds up gradually. So the pressure builds up gradually, and every breath you add more to the functional residual capacity, and you can see at the end the inspiratory capacity is decreased. So this is reduction in the inspiratory capacity. Yes, you're still having the same tidal volume, but the capacity is decreased, and the residual or the functional residual capacity is increased. The question is, what happens next? Does that mean that this is going to keep inflating and then rupture? In reality, no. The dynamic hyperinflation stops at certain point. It is very deep concept. Not sure if I explain it to you here. We can actually capture it. But what will happen is the following. This is volume control mode of ventilation. This is without Auto-PEEP. The pressure, this is pressure, and this is volume. This is the compliance curve. The pressure goes from P1 is the PEEP, P2 is inspiratory pressure. So pressure goes in inspiration between P1 and P2. And the difference between the P1 and P2 is the driving pressure. That driving pressure results into volume. The volume goes from end-expiratory lung volume to the inspiratory lung volume. So let's call this V1 volume. So this is without the Auto-PEEP. Now, when the patient develops Auto-PEEP, we add PEEP to this. This is the PEEP level on the machine. So we add PEEP, and then we move from the P1 will actually go to P3 here, and the P2 will go to P4 here, in order to deliver the same tidal volume. This is volume control mode of ventilation. So this is the volume first time, and this is after we develop PEEP. Here what you see is the P1 is becoming higher, which is the Auto-PEEP. This is a P3, and the P4 is the inspiratory pressure. Now, the dynamic hyperinflation stops where we have a high enough driving pressure to drive the air out. So when the inspiratory pressure is high, going from inspiratory pressure to the Auto-PEEP level would be enough gradient to push the air out. So no more hyperinflation, no more air trapping. So air trapping stops at certain point, whether it's volume control mode of ventilation or pressure control mode of ventilation. Of course, in volume control is the driving pressure that stops the auto-PEEP. In pressure control, it is the less tidal volume that results from auto-PEEP. When the auto-PEEP happens in pressure control, the driving pressure goes lower. Then the tidal volume goes lower and lower, and that actually gets to a level where, because it's so small tidal volume, we're not air trapping anymore. So to answer your question, Ala, yes, sometimes we have to tolerate certain level of auto-PEEP if it is not affecting hemodynamics of the patients, and we're able to ventilate the patient, we're able to oxygenate at the same time. At that time, you may accept a certain level of auto-PEEP. It is a long answer, but I wanted to explain this concept to you so you understand that the lung does not keep inflated. It gets to a level where no more inflation happens. Any other questions?
There's a few questions in the chat. So one of the questions is, what about a brief disconnect to relieve the trapped air?
Yes, and that's what we do in any severe dynamic hyperinflation that is associated with hemodynamic instability. Okay, so the first thing you do if your patient is hemodynamically unstable, blood pressure 70, at that time, since the principle is to provide a longer expiration for the patient, the easiest way is to disconnect from the ventilator. Once you disconnect from the ventilator, the patient will exhale everything in his chest and you eliminate it. Now, when you put the machine back on, you need to adjust it in a way you can provide longer expiratory time for the patient, so this does not happen again. This is a board question, by the way, all the time. A patient with asthma was placed on mechanical ventilation, blood pressure dropped to 70. What's the next thing you do? The first thing you do is you do not decrease the rate, you do not decrease the tidal volume, you disconnect from the ventilator, you allow the patient to breathe. This is dynamic hyperinflation associated with hemodynamic instability. Great question, thank you.
So there's another question or two in the group or in the chat here. So one of the other questions is, what is the effect of putting a PEEP of 0?
Well, it has nothing to do with the generation or building up of dynamic hyperinflation syndrome. However, by putting the PEEP to 0, you can easily get to that level where it can stop. So you don't want to add any more PEEP where you can actually participate in building up that pressure inside the lungs. So yes, you can decrease that PEEP to 0, the external PEEP. That's in patients who are not who do not have spontaneous inspiratory efforts. Again, by adding external PEEP to the patient, in a patient who's breathing on his own, you can eliminate the inspiratory efforts that the patient has to do. Thank you.
Thank you. A few more questions. ARDS with asthma is really challenging case. How can we approach it safely?
It is you need to maintain the principles of protective lung strategy, meaning that the plateau pressure should not go above 30, the driving pressure should not go above 15, PEEP should be adequate for the patient. Of course, when you add PEEP, now we don't know how much of the added PEEP will actually transmit into the alveoli in terms of auto-PEEP. So if you have auto-PEEP, let's just say you have auto-PEEP of 10, and you add external PEEP of 10. Does that mean that the alveolar pressure is 20? No, not necessarily it is 20. So because the added PEEP is actually added to the circuit, and when it gets in touch of the Auto-PEEP that is in the alveoli, there's no way it can push it up. So you equalize the pressure between the alveoli and the airways. Okay, so the added PEEP will function as a way to equalize the pressure inside all the inspiratory circuit. Okay, so your job in ARDS, that patient has Auto-PEEP at the same time, is to measure that Auto-PEEP adequately, because this is what you're going to use also to open the alveoli. Okay, but make sure that you provide enough time. You don't want this to happen because Auto-PEEP you cannot control it. You do not know exactly what is the value of it. You want to make sure that you know how much PEEP you add in ARDS. So you do all what we've done here in this session here to eliminate the Auto-PEEP in ARDS patients. But I want you to know also, a lot of times those patients do not build Auto-PEEP. Why? Because the definition of ARDS is low time constant. Those patients have a very low lung compliance. They can exhale very rapidly. The definition of asthma is the opposite, is high time constant. And the high time constant is because of the resistance. Again, time constant is the time unit that needed to exhale 2/3 of the inhaled air. And the formula for it is resistance multiplied by compliance. So time constant in asthma is increased because of increased resistance. And that's why those patients require a long expiratory time. On the other hand, time constant in ARDS is decreased because of decreased compliance. So if you have a patient who has both ARDS and asthma or severe bronchospasm, their resistance would be increased, their compliance will be decreased, the time constant, it's variable of course, but if the increase in the resistance is similar to decrease in the compliance, the time constant is normal. And it is unlikely that they develop air trapping. Now, if the increased resistance is much higher, or if you set the ventilator at a very fast rate, let's say 40 per minute, at that time you develop dynamic hyperinflation for those patients, and you need to make the adjustments on the ventilator that actually decrease that minute ventilation. Yes, it is challenging, it's difficult. I think it's case by case. I need to deal with it individually. But the concepts are the same. Protective lung strategy for ARDS and providing prolonged expiration for Auto-PEEP.
That's great, thank you. There's a long question here. So asthma with flow obstruction causes Auto-PEEP in a different way compared to emphysema with flow limitation. Do you suggest a different way of dealing with the Auto-PEEP provided the different pathophysiology?
Yeah, that question is difficult because he's right. Patients with emphysema have high compliance. When they develop Auto-PEEP, meaning that the air goes in and does not completely come out, right? The principles are the same. I need to provide enough time for those patients to exhale the air. The time constant for emphysema is prolonged. Why? Because the compliance is increased. So again, time constant is resistance multiplied by compliance. In emphysema, compliance is increased. In asthma, resistance is increased. The end result is the same. Time constant is prolonged. You need longer expiratory time. So the physiology is different, but dealing with the problem is the same. You need to provide prolonged expiratory time. By the way, this is a great question. I need to know who asked this question. It actually represents that you have deep understanding of the pathophysiology associated with diseases.
It was Paolo who
Yeah,
answered.
Paulo, yeah, from Brazil or Mexico, from the name, I guess. If you want to add anything, Dr. Paulo, please unmute yourself and contribute.
Professor, I'm actually from Italy, and thank you very much. Your answer was absolutely clear, and I have no more data. My speculation was only if the different pathophysiology would require a different approach in terms of dealing with the problem. But if on the contrary, the approach from a therapeutic point of view is the same, I'm absolutely satisfied with your answer. Thank you very much.
Perfect. Thank you very much. By the way, for people to know, the scientist who described the most of lung physiology is Dr. Gattagnoni, and I think he's from Italy too. And it's great when you attend his lectures. So thank you, Dr. Paolo, for attending this and participating too. Grace, do we have any other questions?
Yeah, we have a few more questions. So is changing to a larger ET tube helpful?
Well, it is helpful in a way that you minimize the added airway resistance. So the tube has its own resistance. So if you change to a larger tube, you can decrease the airway pressure that is resulting from the tube and the main airways, but you don't change the Auto-PEEP. You don't change the dynamic hyperinflation. You only decreasing the airway pressure by changing to a larger tube. And of course, I would not do it for a patient. If you want to, it's not going to be much difference between 7.5 and 8. It's a little bit of increased resistance because of that difference in the size of the tube. But yes, the larger the tube, the lower artificial resistance added to the circuit, but you don't affect the what's happening at the alveolar level.
Lovely, thank you very much. Another question, any specific rate that could have air trapping?
Well, if the patient is on a ventilator, everybody is different. Why? Because of the time constant. You don't know what, there's no unified time constant for all the patients. Everyone comes with different time constant in asthmatic patients. And the best way is to observe your scalars, the ventilator. Let me get back to it. I stopped it. You observe the scalars on the flow over time. And you need to make sure that the patient exhale all the way out. You need to make sure that the patient empties his lungs. So what you need to do is always observe the flow over time. So you put the patient on the ventilator and you take a look. When you put the patient on the ventilator, you need to make sure, okay, here's inspiration and this is expiration. Excellent. Goes back to 0. Perfect. Now, in fact, actually, for this patient is not asthmatic, actually. I'm just simulating for you. And if you want to increase the rate, well, you would say, well, I do have some time in expiration where I can increase the rate more, because you can cut it here. Perfect. Actually, see, it developed some air trapping. So this patient is not asthmatic. His compliance, his resistance, as you see, is normal, 6. However, if I give this patient a high rate, let's go up to 22 and take a look. See what happened here? See, I'm cutting it off. So this patient is not asthmatic. So you need to avoid having persistent flow. And if you want that high minute ventilation for the patient, if you want that 22, just deliver fast, eliminate any auto-PEEP here, increase the flow, deliver the tidal volume faster. Okay. And then see, we got some more, sorry, go down on the inspiratory time again. So we eliminated everything here. Now look at this, there's still touch of dynamic hyperinflation. Decrease the rate a little bit or decrease the tidal volume and it is gone. Any other questions?
Yeah, there's another question. So how can we explain auto-PEEP with airflow limitations versus auto-PEEP with outflow limitation?
Yeah, so let me simulate this to you. Let me just see how I need to do it fast and then remove it. Okay, hopefully I can do it. It's actually difficult. All right, but let me freeze it here. Okay, so look at this one and this one here. You can see in flow limitation, the peak expiratory flow is decreased. That's number one. And number two, the slope of expiratory flow is shallower compared to the slope here. You can empty faster here. Okay. And number three, you have persistent flow. In patients who do not have asthma but have dynamic hyperinflation, the initial airway pressure is increased, similar to the airway pressure that is increased in auto-PEEP with asthma. However, there is no flow limitation. The expiratory flow is similar. I'm going to simulate it to you in different way, individually, because it's difficult to actually. So first I'm going to give you a dynamic hyperinflation without asthma. Okay. So this is dynamic hyperinflation without asthma. Okay. So let me increase the rate further. And take a look on the flow. Look at the flow. This is the peak flow. Look at the slope, but we have dynamic hyperinflation. Okay. So this is in a patient because you set the rate very high, just 28. You did not allow enough expiratory time for normal physiology, for normal time constant. You just set it on the ventilator faster than the normal time constant for the patient. On the other hand, in a patient with increased airway resistance, take a look here. I'm going to look at this. Okay, this is limitation of the flow compared to this one. Look at the peak expiratory flow, much lower compared to the normal time constant. And then the slope of the expiratory flow is shallower compared to this. Any other question?
Yeah, I think this person is asking when does auto-PEEP need intervention and any public criteria?
Well, for sure, when it's affecting your hemodynamics, you need to eliminate it. But in general, if you can eliminate any auto-PEEP in any patient, I would do it. Of course, we talked the last time on, we talked about ABRV, and the way we generate PEEP for patients with ARDS on ABRV is by creating Auto-PEEP, if you remember. If you were present last week, we talked about that. And at that time, the Auto-PEEP is the desired PEEP that we wanted actually to keep the airways open. Again, when you do Auto-PEEP, that means that you're just a minute, please. So, I'm sorry. So the Auto-PEEP may be desired in certain situation as it improves your oxygenation, but in general, I would eliminate Auto-PEEP completely if it is not needed. And I would like to control the PEEP externally that is set for the patient, so I can actually measure exactly how much PEEP I have. Other questions?
Yeah. So would you be able to explain
You're cutting off.
Pleural fistula with the chest tube in another session? Oh, sorry. Well, this question is talking about future session, and they're just requesting that you talk about a different topic. So I'll get that topic passed on to you after.
I think if the question is about bronchopleural fistula, that's what we're going to be talking about next week. Lovely. We're going to be talking about air leak, and air leak is leaking air anywhere in the circuit, whether around the ET tube, in the pleura, and we'll see the manifestation on the scalars. So that's what we're going to be talking about next week, inshallah.
Lovely, thank you very much. And the final question in the chat is, do you disconnect from the ventilator only if the patient is hemodynamically unstable?
Yes, if you have hemodynamic instability, you disconnect the patient. Of course, you can easily improve any dynamic hyperinflation by disconnecting, but why do you want to disconnect if you can just improve it with manipulation of the ventilator settings? So if it is mild, it's not affecting hemodynamics, just play with the ventilator till you get rid of it. However, if it started affecting your hemodynamics, disconnect from the ventilator, improve it, and then you need to put the patient back on the ventilator. So this patient, you did not solve this problem, you just prevented further hemodynamic instability by disconnecting the patient from the ventilator. When you put the ventilator back, you need to adjust the settings in a way that you don't build the dynamic or the air trapping again.
Someone has just added in another question. Can we use the volume loop presser to know out-PEEP? I don't know what they mean by that, but can you use the volume loop presser?
Well, let me... I'm not sure if I have a... so what he means, the question is, can we use the volume pressure loop to estimate or know exactly the Auto-PEEP? Well, the pressure won't go back to, I don't have it, looks like. The pressure won't go back to the initial pressure. It would actually get back to the pressure point where it is the Auto-PEEP on the volume pressure curve. So yes, you can estimate how much Auto-PEEP you have. Again, Auto-PEEP is alveolar pressure. I think I do. Let me just see. It's very important to understand the difference between, okay, here. Okay, so okay, so what you measure on the ventilator is the airway pressure. So this is the airway pressure. And now when you put the volume with the pressure, you're measuring the red pressure. However, Auto-PEEP is alveolar pressure, and alveolar pressure is the dotted line here. Okay, So this is alveolar pressure, and that's why in order to measure the auto-PEEP, you need to put expiratory hold. And when you put expiratory hold, that red line will go up to the dotted line. And you can see the same thing if you have volume pressure loop. You will see that the pressure won't go back to the initial pressure. It would actually be above it, but that with expiratory hold. If you do not have expiratory hold, what you see is the red line here, which is airway pressure. Again, the machine measures the airway pressure, doesn't measure the alveolar pressure. In order to measure the alveolar pressure, you need to hold expiration, equalize the pressure between the alveoli and the airways in order to measure the auto-PEEP. I hope this is clear.
Can you again get the last
Okay, so what you measure on the ventilator is the airway pressure. You don't measure the alveolar pressure, and auto-PEEP is alveolar pressure. So you can see here, this is the alveolar pressure and this is the airway pressure. And this is what I told you initially, that because of alveolar pressure, you need to go up in the airway pressure to overcome that alveolar pressure first. And then you have the airway pressure. But I mentioned that you first overcome the airway resistance and then you overcome the alveolar pressure. Now in expiration, when you exhale, the airway pressure goes down to 0 or to the PEEP level, let's say, whatever you set on the PEEP. Here it's set at PEEP of 5. The alveolar pressure is maintained at the auto-PEEP pressure, and you have a gradient between the alveolar pressure and the airway pressure. The alveolar pressure is 8 centimeters of water. The airway pressure is 5. The difference is 3 centimeters of water. This is what the patient has to exert in order to overcome this increase in alveolar pressure. And when you add PEEP, you just increase that red line to that dotted line here, so the patient doesn't have to exert any more efforts in order to create a gradient inside the circuit. Okay.
Thank you.
I think we are 10 past my time. Any other questions I can answer quickly?
Yeah, so is there a preferred mode of ventilation other than VC versus PC?
No, you're going to have the same problem whether you have PC or VC. You need to look at the flow, and there's no preferred mode that would diminish or decrease the air trapping for the patient. It's the manipulation that you do on the machine. Now, I would prefer doing volume control because you can control the flow. In pressure control, you can't control the flow, and then you cannot decrease the inspiratory time. With volume control, you can actually control the flow exactly. Of course, you can in pressure control, you can set a lower inspiratory time, so the machine by itself will increase the flow and deliver that volume or the resultant volume quicker. I think it's easier to manage dynamic hyperinflation and asthmatic patients on volume control mode of ventilation.
Lovely, thank you. Another question: if there is no role of increasing pressure support in obstructive airway disease with auto-PEEP, why do we keep it 0?
Oh, I didn't say 0. You keep it at 0. I said you can decrease the 0, but it's not going to affect your auto-PEEP. Auto-PEEP has nothing to do with external PEEP. But when you have a PEEP of 5, that is added to circuit in a patient who's sedated or paralyzed. You're not going to benefit from it. He's got already auto-PEEP. If the auto-PEEP is 10 and you set the PEEP at 5, there's no benefit of the 5. It's not going to overcome the auto-PEEP that the patient has. So there's no value of putting 5. The reason why we put patient on PEEP of 5, because your aim is to improve the dynamic hyperinflation. You want to eliminate it completely, and once it's eliminated, you want to keep some physiologic PEEP in the system.
Lovely, thank you. Do you have time for one more question?
That would be the last question.
Okay, last question. It's ending on quite a long question. So you explain if we add external PEEP when the patient's on volume control ventilation, but in pressure target ventilation, adding additional PEEP beyond auto-PEEP will not increase VT ventilation, but paradoxically might decrease if it is due to stiffness of the lungs. Is this affecting the ventilation, and should we monitor the PCO2?
Well, I need 15 minutes to understand the question, and then probably another 15 minutes to answer it. So okay. You explain if we add external PEEP on the patient with volume control ventilation, but in pressure targeted ventilation, okay, adding additional PEEP beyond auto-PEEP will not increase tidal volume. Well, in both cases will not increase tidal volume. You know, tidal volume that is set on the machine in volume control mode of ventilation is determined by the operator, and in pressure control mode of ventilation is determined by the lung mechanics. So, but paradoxically might decrease if it is due to stiffness of the lung. It's a complicated question. I'm not sure if I'm able to answer it. Maybe I need to sit down with the physician who asked this question. I'm sorry. I don't want to answer a question that I don't completely understand. Is this affecting the ventilation and we should monitor the PCO2? Well, we, all the time. I think in principle, you need to understand how auto-PEEP is generated. If we don't have enough time for expiration in patients with prolonged time constant, auto-PEEP is generated. You need to provide longer time, and of course you need to improve the time constant. How do we improve time constant? Steroids and bronchodilators. Whether this patient is volume control or pressure control, it doesn't make any difference actually. Adding external PEEP is not going to make any difference in terms of ventilation in patient who is not spontaneously ventilating. Adding external PEEP is going to benefit only if the patient is spontaneously breathing. This way, look at this patient here. He's got auto-PEEP of 8. The PEEP is 5. He needs to create a gradient in order to inhale, and he needs to drop the alveolar pressure to 2, and that means that he needs to provide -6 of decrease in the pressure. If you add 3 more centimeters of PEEP, we equalize this, and all what he has to do is just drop the pressure from 8 down to 5. He would need to do only -3 centimeters of water. Of course, the compliance of the lungs may play a role in determining auto-PEEP. The more compliant lung, more likely to develop auto-PEEP. The less compliant lung, like ARDS, is less likely to develop auto-PEEP.
Lovely, thank you very much for answering all those questions. I think we're just going to finish the session tonight, unless you have anything else, Dr. Corella, that you want to add.
I think that's it for today.
Okay, so I'll just recap on some of the announcements that we had from the start. So thanks again, everyone, for joining tonight. I hope you enjoyed the session. We're going to be back again next week at the same time, so 9 p.m. your time for most of you, and that's on Wednesday night. The topic on Wednesday night is going to be on air leak, just like we had mentioned there. There's also going to be another seminar next Thursday night at 9 p.m. and that's on right-sided heart failure, and that's going to be by Dr. Talal Dahan. So if you can make it then, that would be great. Thanks again. The session's going to be recorded and it's going to be uploaded so that you can access it alongside other previous sessions that were also recorded if you want to recap. So thank you, everybody.
Thank you, everyone. Thank you, Grace.